Good evening, ladies and gentlemen, my esteemed panelists, and to all the viewers. I'm Dr. Nishant Sharma, going to be your moderator for the evening, and I welcome you back to another episode of this series of virtual discussions on arthritis in India, a nationwide dialogue. This series is a joint initiative by Voice of Healthcare and Pfizer, where we talk about understanding arthritis, the different management strategies, where we talk about the common myths, the common misconceptions, the variation in prevalences as we see about different public health initiatives, support groups, and everything that revolves around the arthritic space. So, without further ado, allow me to welcome my experts. We have with us Dr. Himanshu Gupta, who's a joint replacement surgeon at AmiCare Hospital, Ghaziabad. Good evening, Dr. Gupta. Thank you for joining us.
Hi, good evening, Nishant. Thanks for inviting.
Yes, and we'll also have Dr. Vinod Arora, robotic joint replacement and orthopedic surgeon from Indore Medisquare Hospital. He'll be joining us shortly. So, without further ado, let's delve into the conversation, Dr. Gupta. What do you say?
Yeah, I think let's start on the time for the sake
Right,
of our
right.
audience. Yeah.
So, for all of our viewers, Dr. Himanshu, my first question will be understanding arthritis. So, what exactly is arthritis, and can you elaborate on the different types of arthritis that are prevalent in India?
So, if we talk about arthritis, the word arthritis means involvement of the joint. That the degeneration of the joint is the term which is used as arthritis. So,
Mhm.
any joint which is undergoing any kind of degenerative or destructive change will be labeled as an arthritic joint. So, the arthritis can be because of various reasons. So, first and the common reason is like injury, trauma. Somebody sustains injury to the knee or to the hip or to any other joint, which leads to destruction of the joint surface. The fracture has destroyed the joint surface. So, once the fracture heals well, if it doesn't heal well in its own place by surgery or by any other means, the joint is going to be destructive and degenerative, and that's called as an arthritic joint. The
Mhm.
second most common reason is a age-related change, which we see most prevalent in our society. That's called as the age-related arthritis, or maybe a primary osteoarthritis. Osteo
Okay.
means joint, osteo means bone, arthritis matlab bone and joint destruction or degeneration. The other kind of arthritis could be some kind of hereditary arthritis like rheumatoid arthritis, by other kind of arthritis which are associated with some kind of skin disorders like psoriasis, Sjogren's syndromes, and other kind of arthritis. And apart from that, some autoimmune disorders can be there also. So these are broadly the kind of arthritis that we see in our clinical practice.
Okay, thank you. Thank you for starting and giving a good introduction to the conversation. Now, let's say a common patient walks into your clinic. What are the common signs and symptoms that people present when they present with arthritis as your clinical practice, please?
So, though arthritis can involve any of the joint, but the common symptoms with which the patient walks into your clinic, first and the foremost, is pain, along with swelling, along with difficulty in moving that joint. And very late in the very late stage, it is the deformity also, which leads to progression, which is because of the progression of the symptoms. So commonly it is pain, stiffness, swelling, loss of movement, and in advanced stages maybe deformity. These are the common symptoms.
Right, and some key risk factors that are associated with arthritic condition, if there are any.
So if we talk about primary osteoarthritis of the joint, the common factor which is involved is obesity, lifestyle disorder, where lack of
Mhm.
exercise is there, where obesity is there. Along with that, the other comorbid conditions like diabetes, hypertension, some kind
Mhm.
of autoimmune disorders, smoking, alcoholism. So all these things contribute to the arthritis, but the commonest reason that we see is lack of exercise, overweight, and associated comorbidities. Yes.
Right, right. So, being a clinician, let's say a patient walks into your clinic, how does a clinician or an orthopedic surgeon diagnosis that a patient has arthritis? Please take us through that.
So as I said, it depends on the joint which is involved, but the common
Hmm.
symptoms with patient present is the same: the pain, swelling, deformity, stiffness, and all. So to diagnose this, we need to examine the patient. So whichever the joint is involved, the first symptom would be pain on movement of that joint. So suppose
Mm-hmm.
somebody is having a knee osteoarthritis. So the first sign that we see is pain on movement, plus some kind of clunk is there, some kind of noise is there, which is because the rough surface of the joint is having the friction when it is moving.
Right.
And along with that, patient will complain of pain. They say that when you are doing this movement, I have a pain. When you touch that joint, it is inflamed, it is tender. There's a
Mm-hmm.
sign the pain will be elicited from that joint. We can get investigations done for that, and the commonest investigation that we see in our clinical practice is an X-ray. It's a common modality which is available in most of the orthopedic clinics. It's a simple plain X-ray of the joint, which
Mm-hmm.
often tells about the kind of arthritis, the level of arthritis, and I think that is sufficient enough to diagnose it. But if we come in younger age group where they have joint pains and inflammation, where you see the X-ray looks normal, but
Mm-hmm.
still the joint is inflamed. In that case, we need to investigate in form of blood parameters. We need to say the inflammatory markers, ESR, CRP. We need to look out for the autoimmune disorders like rheumatoid arthritis or maybe ankylosing spondylitis or maybe any other thing. So there are various modalities to diagnose that. And if you talk about advanced investigations, maybe MRI or CT can be of help into that. But
Mm-hmm.
as of now, for like majority of our patients, X-ray and blood investigation are the key parameters that we follow.
Right. So while we talk about diagnosis, I want your to hear your opinion on how does early diagnosis impact the overall treatment outcome for arthritic patients.
Now that's very important. As I say, like prevention is the key to success. So if you want your joint to behave in a better way once you are diagnosed, it need to be in the early stage that we need to diagnose that arthritis is there. Because if the patients are warned about the pros and cons of the disease, if they are educated enough to take care of themselves and to take care of the joint, maybe the secondary complications can be avoided. There are medications which can be started in early stage which will prevent further damage of the joint. Patients can be educated to do better exercises, to adopt a better healthy lifestyle for their joints to get better in their future. So I think definitely the early diagnosis is the key, which is important. Yes.
Right, right. Thank you, Dr. Himanshu, for talking about and having our viewers understand about the diagnosis, the signs and symptoms of arthritis. Now, moving over to the second important part, which is the management strategies. So, as a clinician, please share some effective strategies that you use for managing arthritis, all in terms of physical lifestyle modifications or medical, pharmacological, or surgical. Please take us through how you decide which treatment is required and what are some effective strategies that you use.
So it is very difficult to tell all these things in a small talk show, but I'd
Okay.
like to just brief them out very quickly. So first and the foremost thing is the age of the patient, which is most
Hmm.
important. So if the patient is young, and if the patient is like young means like middle aged patient, 40, 45 years old age patient who have a significant amount of arthritis, so we need to grade the kind of arthritis it is. The first thing is to grade the arthritis. Suppose in the x-rays we have four grades, one, two, three, four grades. So if we start, one is the less involved joint, to four,
Hmm.
which is the severe and the most involved condition. So, if the patient is young and if he presents to you in a stage 2 or a stage 3 arthritis with certain comorbidities like obesity, hypertension, and diabetes, and all, which is a common scenario, in that case, we ask the patient first is to change the lifestyle, to reduce the weight, because the moment you reduce your weight, the amount of load on your joints reduces significantly. Second is the activity modification. Like if some people, especially in our rural areas, patients are very fond of sitting, squatting, cross-legging, cross-leg sitting and all. And all the biomechanical studies, they say that it puts around 20 to 30 times load when you are squatting or you're sitting cross-legged on your knees. So if a patient is in early arthritis, young age patients, we ask them not to do these activities, not to do anything which puts excess stress on their knees. Like some people are very fond of running, middle-aged people, very fond of doing heavy weight exercises and all. Then they
Mhm.
complain, doctor, I have a pain in my joints. So we need to change that lifestyle. That kind of overuse for the knee should be avoided. Next is to build up your surrounding musculature. Because the moment you have any kind of arthritis, there is pain in your joint, which leads to the weakness of the surrounding muscles, which in turn leads to further pain around your joint. So we need to educate our patients, we need to send them to the physical therapist for routine exercises, which leads to strengthening of their muscles. And apart from that, we give them some kind of pharmacological treatment, like some supportive medicines in terms of micronutrients and all, cartilage medicines to calcium, vitamin D supplementation, depending on what are the parameters which are deficient. Now, coming on to the surgical side, especially for the young patients, it should be
Right.
deferred as late as possible, because surgical options, especially the replacement options, they are reserved for older aged people, plus in very severe arthritis. So, if at all the patients are not responding to conservative treatment, if the demand is relatively little higher, patients are like troubled up with their arthritis, there are various measures in young age to give them some years, some years of this. I would say there are chances of saving their joints. So we have
Mhm.
surgeries for that, and I think that's probably out of the scope of this talk. Now, coming on to older age group patients,
Mhm.
where the age is say like 60 plus, they are active, their joints are totally gone, like grade 3, grade 4 arthritis and all. Now, these are the patients who should be well educated and counseled about the surgical part of the treatment, like the replacement surgeries, because replacement also needs your healthy musculature. They also need your healthy bones to sustain and to
Right.
behave in a better way. So there is always a myth that replacement is always last resort. So it should
Mhm.
not be your last resort, because by the time you are crippled up to be in your wheelchair or in your bed only, and then you adopt with the surgery, probably the bones have become so osteoporotic that they are not going to hold the replacement. Your musculature is so weak that you cannot get up from your position of sitting or lying down. So I think in those patients, those young, relatively old patients who are active enough, replacements and other surgeries are the better choice. But
Mhm.
by the time they don't want it, definitely physiotherapy, pharmacological treatment, and other supportive measures are of help to them.
Right. Any recent advancements or innovative treatments that you have seen in the arthritic management and treatment space that you would want to speak of?
So, if you talk about pharmacological treatment, every few years you will find out a new drug coming up with a very promising result, as in like some kind of collagen substitute, some kind of glucosamine and other things, some kind of intra-articular injections, and you
Mhm.
wait for a couple of years and they vanish from the market. So whatever is there is more kind of a placebo thing, maybe some kind of positive effect on the body. And
Mhm.
more or less, I am not very pro for them, but I tell all my patients, by the time you prepare yourself for any surgical procedure, you can start with those medicines, and some of them, like say like 50 to 60%, they behave nicely. Apart from that, regular supplements of vitamin D3, B12 for osteoporosis, these are the treatments which has got all the supportive literature along with them.
Mhm.
So we start with that also. In terms of surgical treatment, definitely the world has come up very well, and there are a lot of advancements in terms of replacement surgeries. And if you talk nowadays, we are into robotics. So I myself do a robotic replacements of hip and knee surgeries. So the technology is coming up every day, but we need to understand that technology is something which is to help a surgeon to get further better results, but you
Right.
cannot replace that. If you do this kind of advancement, you will be running and you will be doing everything. It is just
Mhm.
an aid to make your patients slightly more better than the conventional things. So
Mhm.
definitely we have advancements, but It's like the basic strategy to treat your patients remains the same.
Right. So, building on right what you said, what are some common myths and misconceptions that people have about arthritis, or let's say any sort of replacement that you'd like to bust today through this virtual discussion?
So if I talk about my clinical practice, so 50% of the patients who are coming to us, they are self-diagnosed with arthritis. Doctor, I have an arthritis. It was diagnosed 5 years, 10 years back. I don't want a replacement. That's their first thing. So first thing is we need to tell them that replacement or any other surgical procedure is only required in a particular stage of arthritis. It is
Okay.
not required for everything.
Hmm.
So we need to discuss with them. So that's the first myth, that if you are diagnosed with arthritis, you will end up into replacement. And if you see a worldwide data, only less than 1 to 2% of the patients diagnosed with primary osteoarthritis, they need a replacement. So here I'm talking about our major joints like hip and knee and shoulders and all. I'm not talking about small joint arthritis, because these are joints which doesn't need replacement. They need pharmacological treatment, they need physiotherapy and all. So the most important part is to educate your patient about the stage in which they are coming up and how they are going to be managed in that stage.
Right.
Apart from that, we have to look for various other constraints of the patient, like their age, their physical musculature, their
Mhm.
comorbidities, and now their economic status also. You cannot
Right.
jump on by saying like India, we have a lot of poor population. Not everybody can afford to have an expensive surgery. So we need to treat them according to their demands,
Mhm.
according to their financial status. So we need to take into consideration a lot many things. So
Hmm.
first myth is, once you are diagnosed with arthritis, you have to go for a replacement surgery. That's a myth. That depends at which stage you are diagnosed and what are the options available into that stage. Now the second thing comes up, the myth. Once your joint is replaced, you will never be able to walk. So I always say I haven't seen a patient where the joint is replaced and the patient is not walking in a proper way. So as I said, I haven't seen in my career of 15 years any of my patients who's operated and has not behaved well. So it
Mhm.
is all about the expectation of the patient. 80% of our patients are happy with the surgery. 20%, even my patients, 20-25% of the patients, 20% of the patients, they are not so happy with the surgery. Why? Because their expectation from the surgery is very high. Like they want to sit cross-legged, they want to climb stairs freely, they want to do every other thing which other people are doing.
Hmm.
Here they need to understand we are just replacing the degenerated part of the joint, the only the involved part of the joint. We are not replacing the entire bone, we are not replacing the musculature, we are not changing ligaments and all. And probably to increase that level of satisfaction, the robotic thing has come up. So I myself have started doing robotics from last 7-8 months, and I have a good number of satisfied patients now. Maybe like more than 90-95% of my patients are satisfied in short term results. But that is just something which we need to see in long term also,
Hmm.
because a lot of the things they depend. See, any of the joint which you have replaced, how well it behaves after 5 years, 7 years, 10 years is more important rather than what is it's behaving in first 2 years. Majority of the joints they behave very well in 2 years. So second myth is that once the joint is placed, you will not be able to walk or you will not be able to do your routine things. It's a myth. You can do anything you want, but your
Mhm.
expectation from the surgery should be true. And
Right.
apart from there are small other things, myths and all, because once the joint is replaced, you cannot get a resurgery done. That's absolutely not acceptable, because once the surgery, because of any reason, has gone bad, or if there is some kind of failure of the surgery, there's always a chance that you can get another joint, you can get other advanced processes and all, you can walk again. So there are certain things. Yes.
Right. Thank you, Dr. Himanshu, for talking about the common myths and misconceptions. So, moving over to the different kinds of arthritic prevalences in India, as you were mentioning about different socio-economic levels of population, or let's say a different age. So, we know that there are also certain regional notable variations that we see in arthritic prevalence. So, well, I would want to hear your thoughts in continuation to the socio-economic variation that we see, the age-related variation we see, rural-urban variation we see in the different types of arthritis, please?
So if you ask me, I don't have any figures for that, but I can tell you from my experience how these arthritis are different in different age groups,
Mm-hmm.
population based, financial and economic status based. So if you see patients who are from rural background, even when they have lot of deformities, lot of degenerative changes in the knee, they behave very well because they have a very strong musculature around, they have a strong endurance, and they keep on walking with those deformed joints. So you must have seen people from villages, they have a lot of deformities in the knee, and if you ask them if you have any problem in your knee, say no, they say no, we are comfortable, we can walk, we can squat and do anything. So
Right.
these are the set of patients who doesn't need any treatment. They have gradually adapted to their arthritis. They
Mm-hmm.
walk in your clinic at a very late stage. Now you compare this with the urban population. They are very well aware people and they are very high demand people. They don't want any nagging pain in their knee. They are not ready to accept anything. So these are the set of patients who walk early in your clinic.
Mm-hmm.
Now this is for primary osteoarthritis. Now if you say religion based practice, there are religious practices where you need to sit cross-legged, you need to bend your knee and you need to sit in a position to pray and all. So these are people who develop arthritis very early in their stage, and their arthritis is pretty severe because it puts a lot of load on their knees. So if you ask about numbers, probably I'm not the right person to tell you the numbers, but definitely there are variations in rural and urban population and all.
Mm-hmm.
Rural people, they present to you with very advanced arthritis and in a very late stage. Before that, they compensate for it. Urban population, they present early, they are more aware, they take care of their joints better.
Thank you. Thank you for that answer. So, strategies for improving the arthritis care that we see, as we know that management of arthritis is requires a multidisciplinary, tailored, unique approach for each patient. How do you feel can healthcare providers and communities and multiple people, multiple stakeholders in the healthcare can work together to improve arthritic care at the grassroots level?
So that's very important nowadays. So I live in NCR, National Capital Region. So it's a very aware society. So we
Mm-hmm.
often see that when we go for morning runs and all, we see a lot of old age people sitting together, discussing about arthritis, their experiences and all. So first and the foremost thing is the awareness of the society.
Mm-hmm.
Like what we are doing right now is just a health talk on arthritis. So
Right.
similarly, nowadays in communities like the condos, there, the parks, and everywhere, there are camps which are being organized by a healthcare organization about the awareness of arthritis. That
Right.
if you have these symptoms, come and visit your doctors. There are various kind of camps, BMD camps, diabetes camp, and everything happening every nick and corner of our societies just to create that awareness. So the first and the foremost thing is to create that awareness
Mhm.
that every arthritis is different and we need to understand how to prevent that and how to treat that. That's the most important strategies. And I think now various government programs are also coming up. The campaigns are being run at different levels to
Mhm.
diagnose early and to treat early. Next is once you are diagnosed with the disease, you need to see the right people. You don't need to go to quacks. Don't need to go to some other pathies to get themselves treated for that. They should be well educated that this is the stage of arthritis and this is the treatment that you need to we take that this is the treatment that you need to start with. So it's all about educating the patients, it's all about reaching them early, it's all about
Mhm.
guiding them the right treatment. And I think the government, the healthcare providers, the corporate hospitals, the clinics, and everybody is doing their job into this. I think that's the best strategy to deal with it.
Right. Thank you. Thank you for that. So, any organizations, either governmental or non-governmental, that you're aware of, which is taking huge steps in raising awareness or creating support for arthritic patients that you would like to tell to our viewers?
So if you ask me about orthopedic organizations like we have the Indian Orthopaedic Society or Arthroscopy Society or replacement societies. So these are like the bodies which are conducting their regular programs at different levels, like the community levels and all. We have those chat shows, they are like walks which are being organized. I have really no idea about the government or organizations who
Mhm.
are looking particularly for the arthritis, because see, we have such a vast population base. We have many more important things the government is doing at their level. So I think here most of the orthopedic people, the therapists, and all, they are conducting these kind of programs to make their way. So I have no idea about the government organizations.
Okay. Okay, thank you. And any public health initiatives or programs that you're aware of, which are catering to the unique needs of, let's say, the vulnerable population, the elderly, which we know, or maybe the limited people with limited resources.
I
Uh,
have no idea about the public health program
okay.
which is running for the
No,
arthritis.
no problem, sir. So now that we have discussed about what arthritis is, how do we diagnose, what are the different management strategies, now talking about someone living with arthritis or maybe in the early stages of arthritis, what preventive measures do you suggest to people, two different parts of people? One, people in the early stages of arthritis so that they don't progress into arthritis as quick, or maybe if they can prevent arthritis at all. So being a clinician, over to you.
So, first is preventing the arthritis. See, I am young, I don't have an arthritis right now, but
Mm-hmm.
I don't want this arthritis to come up to me. That's
Right.
first question. So, for that, if you don't have a family history, a hereditary history of any kind of autoimmune disorder or any kind of comorbidity, you are a low risk patient. Second is you have to keep your BMI on a lower side. You need
Mm-hmm.
to be really active. You need to exercise regularly. You need to take care of your diet. You need to be like in your weight proportion to the height. So these are the measures. And apart from that, once you start having early symptoms of arthritis, you need to see the right people. That's most important. Right people means right doctor, right therapist, and right advice. So if you start your medical treatment early, probably you are going to delay the arthritis. So the
Mm-hmm.
common problem, the common kind of arthritis, which are often misdiagnosed in younger population, are the autoimmune arthritis, like
Okay.
rheumatoid arthritis, like ankylosing spondylitis, like arthritis associated with any kind of skin disorders.
Mm-hmm.
So these people are not aware that they are going to build up arthritis into future. They say, my mother has got an arthritis. Now, doctor, I have a joint pain.
Mm-hmm.
Well, I'm also getting that arthritis. So they are not aware what kind of arthritis their mom has got, whether it's a rheumatoid arthritis or it's a age-related arthritis. So if it's a
Mm-hmm.
rheumatoid arthritis, that patients come into an high-risk group. So we need to screen those patients early.
Correct.
We need to take their parameters in control before the arthritis hits it. So that is important. So you need to get yourself screened by your doctor to diagnose your arthritis early. But this is only a very small subset of patient who has got any kind of autoimmune disorder or something like that.
Correct.
Plus, you if you are in a high risk group, like if you are a diabetic, if you're a smoker, if you are like hypertensive, you are bound to have joint pains. Now, this is the condition where you should meet your clinician early, because once the joint starts degenerating or the arthritic changes have built in, they are irreversible. They cannot go back. So you need to intervene early. So that's how we should proceed for that.
Right, right. One bonus question that I have here is I have been taking a lot of these virtual discussions on arthritis. We hear a lot about the psychological issues that a patient living with arthritis has. So I want to understand your views on it as well.
So first and the foremost thing is how we accept our arthritis, and like as I told you, you need to be aware of what kind of arthritis you are going through. So I have seen patients who have this rheumatoid arthritis diagnosed at a very early stage, or ankylosing spondylitis which is diagnosed at a very early stage. So these are the patients which need to be counseled well, because they have an entire life ahead. They need to take the treatment regularly. Now, if you ask about the psychological impact of the disease, that depends from patient to patient,
Okay.
and that depends upon how the surrounding is responding to that also, the how the family is supportive to that, how your doctor is supportive to that, how your therapist is supportive to that. So I have a lot of friends who have rheumatoid arthritis or ankylosing spondylitis, but they are running marathons and doing everything. Now, there is a set of patients who are diagnosed with early arthritis and they are not able to do anything in their lives. So, that depends from patient to patient. So, the psychological impact of the disease is different in the age group also. Now, if you see about the old age psychology of arthritis, the moment you tell them that you need any kind of replacement or any kind of surgery, now they are different people. Now, the psychological impact of the disease in that age group is different. They think like, now our age has passed, we don't need any surgery, we don't need anything, we can live with that. But that negative impact of the psychology will lead to further deterioration of the disease, and sometimes it becomes a burden on the family also. If you are not moving, if you are not doing anything, your comorbidities will also increase, your diabetes, hypertension and everything is also increased. So we need to counsel our patients very well that this surgery is not only to make you mobile but to make your other parameters better also, because if you keep on moving, if you keep on doing your activities, probably the things will be more in control. So
Correct.
that's how the psychology is different in different age groups. So, but you need to counsel your patients really well for all
Mhm.
these things. I'll just take a
Right.
moment from ours. Yeah.
Yeah. So as we move towards the closure of this panel, Dr. Himanshu, my last question for you, a message that you'd like to give to all the viewers, be it your colleagues, be it patients living with arthritis, be it caregivers, a message, a take home key message that you'd like to give to everyone who is watching, please.
So my message to the society and to my viewers is arthritis is curable. The only thing is you need to come up early to get it diagnosed. Your diagnosis has to be accurate of what kind of arthritis you are going through and in which stage you are actually taking treatment. If at all your joints are gone, don't be scared to undergo surgeries, because surgeries are to make you better, not to make you worse. They will give
Right.
you better mobility in your life, better confidence in your life. And if you are not a candidate for surgeries, you have a lot of other measures to live to make your life better with this arthritis. That's my message.
Yes. So with this, I'd like to bring this session on arthritic awareness to a closure. I'd like to thank all the viewers. I'd like to thank Pfizer for powering this, and finally, I'd like to thank Dr. Himanshu Gupta. Thank
Thank you,
you
Vinod.
for sparing time out of your schedule and stepping up with us in creating this awareness. Thank you. Have a good day, sir.
Thank you, Nishant. Thank you. Bye. Thanks.